Welcome to Chapter 12 of Social Work 121. In this chapter, we are talking about working in the healthcare industry. We're also talking about the health of Americans and what might be done to improve it. So, this industry is growing. It is huge to begin with, and it is continuing to grow for a few different reasons. We have a lot of elderly people, and elderly people tend to use a little bit more, or actually a lot more, healthcare services. And we keep coming up with new cool ways of treating people. And so social workers can be found on the treatment level, like working one-on-one or even with, groups of people doing things related to healthcare, but they also can be found on the macro level doing things like policy and procedures and even laws around healthcare. When it comes to trying to understand how healthy Americans are, there are 5 keys to understanding what's going on. The first is that unhealthy lifestyles are pretty prevalent in the United States. We typically think about a lack of exercise and a lot of fats and cholesterols in our diet, and those things are true, but it also relates to cigarette smoking, although that is down, especially among the young. But being overweight and being obese are increasing in prevalence. And then high levels of stress. And stress is one of those things where a little bit of it is good. When the bear is chasing us, we want to have some adrenaline pumping through our veins to give us that extra head start. And so the same thing occurs when we're in traffic and we're having it's a kind of a dangerous situation, and the adrenaline makes us more alert and allows us to think quickly, and so that's good. The issue that many Americans have is that it's never not in a situation where they're in a high stress situation. So a little bit of stress is good. A lot of it turns down the immune system. If you think about if you're being chased by the bear, which by the way, our body does not tell the difference. It can't tell the difference between whether we're being chased by a bear or when we're watching, say, a dramatic movie and we're feeling like we're being chased by a bear, or we're feeling like the gunman is following after us. Oh, so if you're being chased by the bear, then does your body want to spend time, say, healing cuts? No, it doesn't, because it's not as important. If the bear catches us, then whether our cut isn't going to have the opportunity to get infected. And so our immune system kind of tapers down when we're in high stress. When we're more in relaxed mode, then it can say, okay, what can we do for the long-term health of the body? Moving on, physical injuries are prevalent, especially among the younger population. And the big one here is motor vehicle accidents. Although thanks to safer vehicles and laws that mandate things like not using your cell phone while you're driving and mandating the use of seatbelts, vehicles are getting safer, but they are still a prominent part of the reasons why people have health problems related to physical injuries, but then also physical injuries could be related to homicides and suicides, although I think both of those run at about 15%. So, environmental factors are another thing that contributes to the health of Americans. Air quality is a real concern, especially in urban areas. Water pollution is an issue. We have laws, the Clean Water Act, but unfortunately those aren't enforced very well. So you're going to end up with things like pesticides in the water and in foods. And things like nuclear waste and industrial waste are things that are, if you take something and you dump it onto the ground, or you bury it, in a hole, the earth is a system, and what goes to one place often has a way of seeping out and kind of going everywhere. So, for instance, they say that plastic, which is a fairly new invention, is actually everywhere. They say that plastic is in our water, it's even floating around in our air, it's in our bodies. Second to last thing here is poverty. So poverty is something that kind of makes pretty much everything worse. I mean, there's a couple of good sides to poverty, like you may realize that you have to form stronger relationships with people, or connect more spiritually. But in most cases, poverty causes things like a greater chance of malnutrition. So if you look at who is malnourished in the United States and even who is obese, because obesity is not necessarily the same thing as being nourished. In fact, even though we have record levels of obesity, we also have record levels of malnutrition. Even things like vitamin C, we don't get enough of it. We have lots of simple carbohydrates, simple fats, potato chips, lots of breads and cereals, but those don't have the nutritional value that that our body needs. And in my mind, that's one of the reasons why we keep eating, is because our body is looking for nutrition, and so we're eating breads and fats, and our body's like, actually, I still need vitamin C, and we're like, well, I'll have another bagel. It's like, well, actually, I still need calcium. All right, well, I'll have some Doritos. And so our body's making us hungry, but we're just not reaching for the nutrition that it needs. So poor indoor air quality, especially for the poor. We have higher death rates among the poor and a lack of access to medical care. If you look at especially rural poverty, people in rural areas have a lot less doctors per 1,000 people than in the more urban areas. And then also unsafe water. How pure is your drinking water? Well, if you go amongst the poor, it's not as good. If you go amongst the rich, it's a little bit better. Contagious diseases are another thing. Contagious diseases is not something that I personally thought about very much until COVID-19 hit. COVID-19 is the third largest cause of death in 2020, and it's on track to be that way for this year as well. So contagious respiratory diseases, sexually transmitted infections, and then in addition to COVID, respiratory and intestinal diseases that are contagious, one from another. Let's talk about medical social workers. So there are some social workers who decide to specialize in working with patients who are having medical issues. And so they may work in a medical facility such as a clinic or a hospital. They are oftentimes working directly with patients, supporting them as they leave, and that would be an example of a direct patient to social work relationships. But there are a few social workers that work on policy and procedure planning, kind of on the upper levels of administration. Social workers can work in hospitals, medical clinics, diagnostic and treatment centers. What would they do there? They would help patients interpret medical jargon, right? Which there is plenty of it. In many of the healthcare fields, there's lots of things that doctors may talk to patients about that patients are, just really not understanding what's going on with their own health. And the doctors are under very strict time constraints, so they may not have time to explain those sorts of things. So the social worker can kind of come in and try to explain, this is what is going on with your body, and this is how it may impact your life, right? Because if people don't understand what's going on in their body with their health, it is very unlikely that they're going to feel like a powerful agent in their own healthcare, which is important. People do much better when they feel like they have ownership over their own lives. Social workers can offer emotional support. Hospitals, medical issues are very scary. I mean, even if you don't have a medical issue, just the idea that you might one day have something go wrong with you, it feels out of control. It feels larger than you. So social workers can help people see their situation objectively. They can see that actually this number of people receive this diagnosis every year. This is oftentimes the treatment, and this is the outcomes that can be expected. And this is how it may impact your life. These are the pros and cons of various treatments. In addition, some patients will receive a terminal diagnosis. Terminal diagnosis would be one that is going to lead to their death in a rather short amount of time. And this obviously can be very traumatic news for somebody, and social workers can help those people deal with their feelings and which can be wide and varied. Elizabeth Kubler-Ross came up with the 5 stages of death. When you receive a diagnosis, and so things like anger and denial and bargaining are all very common things to go through. Additionally, social workers can help people make end-of-life plans. What would you like to accomplish? What would you like to do before your life ends? Is there anything that you'd like to create, like a video or maybe a book for the people who you are going to leave behind? And it's important also to not shy away from that reality. Oftentimes people who are dying actually want someone to talk to them about the reality of their death. Unfortunately, we are pretty uncomfortable with the idea of people dying, and so even when it is pretty obvious that they're dying, we're kind of like holding out hope that maybe some miracle and last-minute thing might actually help them. And maybe it would, but we're also missing that opportunity to be able to have that conversation with that person that maybe they really want to have, but they just don't feel like people actually want to talk about the fact that they are going to die. Helping patients adjust to new conditions after returning home. How does somebody's life need to change in light of their new health issue? Especially if you think about things that would be very life-altering, such as recently becoming blind or having a limb being amputated. Helping parents whose children have serious illnesses or disabilities. Helping parents cope with issues of shame and anger and adjustment to having a child whose future may look different than what they were intending, who may need accommodations and to have schedules be rearranged in the present moment. And then last thing is to help patients make financial arrangements to pay for hospital and medical bills. This could include things like helping them contact insurance companies, helping the person apply for financial aid, and understanding the rules and policies around who gets aid for their bills and how should things be paid for, what order, and what happens if they have to file for bankruptcy, and just things that are related to healthcare expenses, which unfortunately in this country are very expensive. I'll talk about that in a second. Let's talk about public health, though, at the moment. Public health is a complex system of healthcare programs and policies that try to address the public's health on sort of on a large scale. So, for instance, the person who's maybe has a toothache, going to the dentist and having the dentist fix the tooth and then being done. That is what most people think about when we think about healthcare. But public health would be saying, what can we do to help all people's oral health? Can we educate children when they're in the school on how to best care for their teeth? Are there things that we can do in the water that would be able to help all people to have better oral health? So, for instance, what do they add to water? Fluoride, right? The idea of that is that everybody receives the same, treatment, and they receive that in their water, and that's going to strengthen their teeth. So doing things like encouraging healthy lifestyles. We have ad programs that help people understand, you should be eating more whole grains and foods that are fresher rather than canned, and people should be, avoiding smoking. Also conducting research on what actually affects people's health. We have all kinds of ideas about what is a perfect diet for someone to be on. Should they eat lots of meat? Should they eat very little meat? Should they eat lots of carbs? Should they eat lots of fats? Should they eat 1 time a day? Should they eat 3 times a day? And so there's lots of ideas out there. Some of them are crazy. Some of them seem to work, but it's hard to know, like, what are the long-term effects of, say, a low carbohydrate diet. And so public health would say, let's invest some resources into studying things to know what is actually going to be effective in improving people's health. So, Veterans Affairs are programs that are set up to serve veterans within the United States. It is the biggest healthcare operation in the country. It serves 8.3 million veterans. There are about 150 major medical centers around the country. There's one right here in Marion, Illinois. And in addition to these 150 major centers, there's 1,700 smaller, 1,700 sites, and some of them are much smaller. And these are going to do things like have community-based outpatient clinics. And so an outpatient clinic would be something that someone would go to. They're not living there, or they're not sleeping there. That's why it's outpatient. And they may be receiving a service like receiving vaccines, or they might be receiving mental health treatment there, maybe once or twice a week. Other things include community living centers, vet centers to help people who are returning from combat overseas, to help them adjust to life, civilian life back home. And the Veterans Affairs doing jobs like what I just described. About 11,000 social workers work there. So, all right, let's move on to managed care. So Veterans Affairs and those centers and hospitals and outpatient centers, those are run by the federal government. And managed care is a practice and plans that seek to try to limit individual medical visits and treatments. So managed care is different from traditional care in the sense that managed care tries to control or manage the care that people receive. And so starting in, I think, the 1980s, the cost of medical care started really increasing pretty dramatically. And so there was an attempt made to control the amount of costs. And so doing things like creating limits for patients. Maybe in the past a person would see the doctor that maybe they grew up with, but if that doctor is not within their network, let's say, they won't be able to do it. And the way that doctor would get into their network is that the doctor would say, I'm going to agree to accept this amount of money from this specific insurance company. And so then these plans, have certain people that are in network and some people that are out of network. The idea being that you are going to save money because you're going to be creating systems and agreements to reduce the cost of healthcare. So social workers can work within this system, trying to make the best of a situation where there are limits put on patients. There are limits put on practitioners in terms of what the insurance company will pay for. And advocating for patients within this system. Maybe the insurance company says, we're not going to pay for this because we don't usually pay for it. And the social worker may be able to advocate and say, actually, I know you don't usually, but here's why you should in this situation. The insurance company may need a social worker to advocate on their behalf. The doctor's office may say, this is what I do, this is why I think we should be done. But the social worker working on behalf of the insurance company may say, actually, here's why we don't want to pay for this. Here's why we don't want you to do this for our client. The Affordable Care Act is also sometimes referred to as Obamacare. As healthcare has become increasingly important, the question of how do you manage it looms large, because it's very expensive and you've got a million different players, and you also have several different agencies within the government paying for it. You have people, and some of them are paying out of pocket, and some of them are paying in additionally with health insurance companies, and other people are using healthcare benefits through the Veterans Association, and some people have Medicaid and Medicare. And so there's just really a lot of things going on within our healthcare system. And so the Affordable Care Act was trying to bring some order and reduce the costs. That was one of the desires. If you think about the title of the bill, the Affordable Care Act, it's supposed to make healthcare more affordable. And it was also supposed to open up healthcare to more Americans. And most rich countries have some form of nationalized healthcare. And what nationalized healthcare is where the government either provides the healthcare itself, kind of like when you go to the driver's license bureau, or the police. You go to the police. That is the government doing law enforcement. Most other countries have that, or the government acts as a health insurance company paying the private providers there. So the United States did not have that system before the Affordable Health Care Act. When it comes to healthcare, there's a couple of opinions on this. And so typically more conservative people say that the government should stay out of healthcare, that this is something that the private sector, the doctors, the insurance companies, they can figure this out on their own. And if people want to go to their doctors and receive treatments, then they will, and those doctors will be paid for. But if they don't, then they won't. And so that the government is only going to kind of make things more complicated and mess things up. And then you have liberals who say that the government should play a huge role, and that the government should do like what Canada does, where the government should basically be everyone's insurance policy, kind of like a Medicaid for all, or Medicare for all. So everybody should have the government be their health insurance provider, and then it's going to pay the private doctors and therapists and things like that. So the Affordable Care Act, contrary to what you might have heard, was sort of a meeting in the middle of these two. It sort of combined a little bit of what the liberals wanted and a little bit of what conservatives wanted, and kind of brought it together into a system where the government provided this website. I think it's healthcare.gov, and so that's that's the government doing that. And the government then, threw some money at people to help them pay for their health insurance. But then it tried to create some competition on this webpage by having the different insurance companies compete with one another after people, plug in their information. So this is their age and this is their risk level and things like that. And so originally, the bill mandated that people had to have health insurance. Now, that has kind of gone away. They modified that, and so that people no longer have to have health insurance. But that was one of the original goals of the Affordable Care Act, to have every American have at least some form of health insurance. It also allowed people to get on Medicaid who otherwise would not be able to get it. It ended lifetime maximums. So sometimes insurance companies would say, we are only going to pay $3 million for your care over your lifetime. And then after $3 million, we're no longer going to be your insurance company. And so the Affordable Care Act eliminated that. It also eliminated insurance companies' ability to reject people because of pre-existing conditions, such as if they had cancer, then insurance companies would say, we don't really want that kind of a patient. And so the Affordable Care Act says, nah, you actually don't get a choice if you want them or not. If they choose you, then you have to accept them. And so other things as well. Unfortunately, this is not me giving my opinion, the cost of healthcare did not go down, and it didn't even remain stable because insurance companies were forced to take more risky patients. The insurance actually went up. Although some people receive money from the Affordable Care Act to help them pay for their health insurance, so that may have been gone down for individuals. So nonetheless, it is a controversial bill that is kind of still being contested, and it's being taken to court. I think it's been to the Supreme Court at least 2 or 3 times already, but so far it's hung in there. So, well, let's talk about problems within the United States healthcare system. People in poverty have inferior health compared to people who are not in poverty. People who are racial minorities, they also are experiencing inferior health on average. They have less access to health care. They tend to have higher levels of disability. They tend to retire due to that disability sooner and not live as long, have higher infant mortality rates. They have higher substance abuse issues. They're likely to go without seeing a doctor for longer. They're more likely to be uninsured. So, all right, so that's that. There's that problem. Also, the cost of healthcare seems to be ever escalating. The U.S. pays more than any other country in the world for healthcare, and yet our healthcare is not anywhere near the greatest. We pay roughly $10,000 per person per year for healthcare. So why is it so expensive here? Why the cost not going down or even remaining stable? So a few reasons here. One, we keep coming up with new things, new ways of treating people, and many of them are pretty technical and involve large machinery that is expensive to purchase and requires specialized people to run. We have high rates of obesity, although that's contested as to whether that really causes us to spend more on healthcare. We do have high administrative overheads. So you have a lot of administrators, presidents and people who are at a high level within major medical centers like big hospitals, and they have large salaries, and that causes the healthcare costs to go up. Our book says that it costs 6 times more for us to do administration than many Western European countries, and Western ones are typically the rich ones. So, prescription drugs are very expensive and expected to increase much more into the future, to the point where prescription drugs are actually expected to be more expensive than visiting healthcare providers and getting treatments that are not prescriptions. Healthcare insurance is run for profit, and as their costs increase, they pass those costs along to the consumers. But also, they want to make a profit, which means that they have to charge more than it costs them to provide healthcare. In 2020, 32 million Americans did not have health insurance. This has actually gone up significantly from where it was, I think, about 5 years ago. We were down to, I think, half that amount. And what's the problem with people not having health insurance? Well, they are oftentimes reluctant to seek medical care because they're paying for it out of pocket. And oftentimes people who pay for medical care out of pocket actually pay the most. Sometimes it seems as though healthcare or health insurance companies just kind of cause providers to just shrug off a significant portion of what they would charge. And it's almost like you're having almost a large, muscular, aggressive looking person kind of following you around to your medical providers. And when they are with you as insurance companies, they may not even actually pay part of your bill, but just they kind of look mean enough for your provider to kind of drop the cost of treatment for you. When people don't have insurance, they oftentimes don't receive preventative health care, like immunizations or like seeing the doctor when they are first pregnant. And then if they have no health insurance and providers won't see them, which is in the right of doctors, for instance, to not see patients who don't have health insurance. Well, there's one place that will not turn them down because it's not legal for them to turn them away, and that's the emergency rooms of hospitals, which is the most expensive care that one can receive. And so, for instance, if a person is on the streets and they have a tooth infection, they may go to the doctors, the oral surgeons, the dentists to try to get treatment, but the people may say, well, no, you don't have the ability to pay, so therefore we're not going to treat you. And the time passes and the infection gets worse and spreads to the heart, and then that person goes to the emergency room, and that person may be in there for several weeks, costing hundreds of thousands of dollars, because that was the place that could not turn them away. Well, let's talk about cultural competence, because oftentimes medical providers have the ability to help people, but they may have trouble communicating with their patients due to the fact that the patient's culture and their communication styles are different, and that acts as a barrier between patients and their providers. So when you think about cultural competence, just think about being able to understand each other well. And this is important because we are more diverse today than we were in the past. So here's like some examples of where cultural competence would be really important. Cultures practice a preference for parents' well-being over the children, over oneself. And this is going to be important because as an American provider, you might be thinking, what do you want? What is important to you? What is best for you? And the person may say, it's not really about me. It's about my parents. It's what they want. That's what I want to do. So, also, collective decision making may be very important to them. They may say, I'm going to receive the treatment that we as a group decide is best. So, and then an emphasis on harmony. And this one gets me because I oftentimes think that we don't address the conflicts because we're afraid of disrupting harmony. We're afraid of rocking the boat. And this would be a challenge for me because in some cultures, harmony within the family is more important than getting to the truth or having people's issues brought to the surface. In my mind, I'm thinking, boy, everyone's tiptoeing around the person's substance abuse because nobody wants to disrupt the appearance of harmony and peace. And so this can create other problems such as informed consent. So who gets to know what's going on in the patient's life? Who gets to decide what happens when the person isn't able to make their own medical decisions? And then end of life plans. Who is making the decisions in terms of, do we seek more treatment? Do we go to hospice care? What is going on? And again, as an American social worker, I'm thinking we need to focus on that person, making them feel powerful, making them feel like they have ownership over their own treatment, over their own life. But that may not be practicing cultural competence in all situations. So how does one empower people who have serious health conditions? How do you help somebody see their condition not as the end of life as they know it? So this may require the person creating new goals for their life and even new identities that they may have to create if, say, they were to be somebody recently diagnosed with a disability. And so what makes people feel powerful in their own life is the ability to self-direct. So helping them see, here are your options, but ultimately you want that person to feel like they have a say in what happens in their own life, right? And what makes people's life meaningful is being productive, doing something to help out generally other people, but it also could be animals or nature, or something that they find meaningful, and then helping them stay engaged with people. And this may be helping them find a support group of people who have a similar diagnosis as them. So that is Chapter 12, Working in the Healthcare Field.